Hey everybody, thanks for checking out my channel this week. So this week I want to focus on the ideas of equity and equality. So what is equity, what is equality, how does this relate to the distribution of healthcare services and to health in general? So first I should probably define what is equity and what is equality. Now I know when I first learned these definitions I found it really hard to tease them apart because they do have a very similar basis. They're both based in fairness and injustice. But equality is more concerned with giving everyone the same outcome regardless of inherent differences. And equity, on the other hand, is concerned with providing everyone with the same quality of outcome, bearing in mind those inherent differences. Now, if this is still a little bit confusing, there's one explanation that's really helped to drive this point home for me and help me to make the distinction. So I'm going to try and use that right now, and maybe it'll help drive the point home for you. So if we think about the Olympics, because they're going on right now, and we think about the 400-meter men's hurdles, if we think about the track and the runners that are running in the race, if we looked at it through the lens of equality, we would say that those runners should all start at the same point on the track. But if we look at the track, it's in the shape of an oval, and we realize that those runners that are on the inside lanes actually have a distinct advantage over those people on the outside lanes. They really actually have to run a shorter distance. So how do we address this discrepancy? That's where the idea of equity comes into play. So the principle of equity would have us stagger the starting positions of the runners in order to offset the disadvantage that those on the outside lanes face. This in turn ensures a path to fairness and justice. Okay, so now I hope you guys have a better idea of what equity and equality are and what the differences are. In this way we can move on and apply these concepts to health. So in Canada, we take great pride in our healthcare system. We love it. We tell everybody about it. It's a publicly funded system that's rooted in the ideas of publicly administered, comprehensive, universal, portable, and accessible care for all Canadians. Essentially, it's designed to ensure that all Canadians have the same access to healthcare providers and services regardless of their ability to pay. Yet, time and time again, research shows that certain populations are disadvantaged by this system, and it's because it doesn't take into account the social determinants of health. And these can be things like spoken language, place of residence, sexual orientation, gender, level of education. So what is the problem then? The problem lies in equity, not equality. And in the article that we read this week from Braveman and Gruskin, hopefully I said that right, equity in health is defined as the absence of disparities in health and its key social determinants that are systematically associated with social advantage, disadvantage. They go on to explain that then health inequities systematically put populations who are already socially disadvantaged at further disadvantage. So by pulling on some of the topics that we've discussed this week in class, I hope to do two different perspectives. One is going to be from an article that talks about some systematic inequities that are still existing in our healthcare system, and the other is going to focus on some places where we're making some gains in the global scale when it comes to equity in health. So here we go. Okay, so first I want to talk about an article that was featured on CBC News. It put the spotlight back on the extensive wait times that Canadians face when they go in to see their family doctor or they go into the emergency room. Now, this isn't a new concept, it's something that comes up all the time in Canada, but what was new was the report that it was reflecting on, and this was a report that was put out by the Health Council of Canada, and it was called Where You Live Matters. Now, I mean, I love our healthcare system and I realize that it has flaws, but I was actually shocked to find out that compared to all the other countries that were included in the report, Canada ranked the lowest when it came to the length of the wait time that people had to endure before they could see their family doctor. Now, if you look further into the report, it explains that despite the constant talk about wait time reform here in Canada, there really hasn't been any major changes since 2004. And in fact, of the Canadians that they surveyed, only about 31 to 46% of them could get a same-day or next-day appointment. Now, when I thought about this has several bad implications, but the one that really stuck out for me is that if these people can't get the care they need, they are going to go to the emergency room if they can't wait. If they choose that they can't wait, they're going to go to the emergency room. Now, if you compound this with the people in Canada that do not have a primary health care provider and have to go to the emergency room for their care needs, that means that it's not shocking that about 26% of Canadians will experience a wait time that's longer than 4 hours before they can be seen in the emergency room. But what does that have to do with equity? If you go on to read the report further, it's revealed that where you live in Canada can also have an effect on the wait time that you experience. And this is increasingly true for those individuals who are considered to live in a disadvantaged population. So I took that report and then I looked at another wait time report, which was called A Time for Transformation. And this one was put out by the Wait Time Alliance. And it goes on to explain that the social determinants of health can influence the population and determine who has access to the healthcare system and in what manner. They then describe that how the burden of illness is felt disproportionately by those of the lowest socioeconomic group, thus causing them to utilize more health services than those of a higher socioeconomic status. The truth of the matter is that many of these patients are required to use the ER for non-urgent care needs because of the barriers they face to traditional primary health care. In fact, individuals from low economic areas said that they were more likely to report difficulties making appointments with their family doctor for urgent or non-emergent care needs. So how do we fix this? That's the question. And if you look at that report, they came up with 3 solutions. There was a couple more, but these ones really stuck out to me when I was going through the report. So the first one I would narrow it down to saying better matching of services to patients. So they were saying that hospitals are partnering with the Institute of Healthcare Improvement in the United States in the hopes of developing a means of tracking high health system users and providing them with more specialized care to meet the needs, because they obviously have a greater need. And then the second one would boil down to primary care intervention. So they were talking about a program called Health Links, and they were saying that it would seek to identify health system users that use the system frequently and put them in contact with a primary care provider who can act as a point of contact or a liaison that would intervene on their behalf to ensure better coordination of healthcare services. And then the last one was wait time guarantees. So there was something that they had mentioned from Portugal, which had said that Canada should look at a means for developing a centralized electronic platform that facilitates the movement of patients across the country to receive faster service in another area if they cannot receive it within the province that they live in. So maybe these are some ideas to move us forward. So before I go into talking about the article that I want to talk about for the second half, I should probably give a little bit of background just to help with context. So in 2008, nearly 1.4 million women worldwide were diagnosed with breast cancer. And of those diagnosed, an estimated 450,000 of them will die from the disease. Now, not surprisingly, this is felt disproportionately by women living in low socioeconomic status areas. And they often cite barriers to screening and treatment as the major cause. Now, after reading this article, it really gives me hope, and hope that we can, tackle this issue. A researcher by the name of Dr. Sheikh Ahmed is trying to address the same issue, but in Bangladesh. The headline of the article reads, "In Bangladesh, serious obstacles stand between the 30,000 women who contract breast cancer in a given year and the care they need. Poverty is pervasive, health insurance almost non-existent, and 4 of 5 women are Muslim, with a strong preference for a female physician. This is a rarity in the rural nation. One aspect of Bangladesh life, however, is an uncharacteristically easy access to wireless phones." So the goal of the research project is to empower women by developing a phone-based application which will help them to stay in contact with their medical care teams. So the technology is geared towards pain management for those women suffering from advanced stage breast cancer. Then by answering a series of questions which would mirror something like you would have with your doctor in an office visit, the application can tell if there's any serious changes. And if a serious change is detected, then the doctor is notified and a course of treatment can be changed from a mobile place. Now, I think this is an amazing initiative and a great use of technology. By giving women the opportunity to have equitable access to specialized care, healthcare practitioners are empowering women to help themselves overcome the barriers that move them from choice to chance. And I think it's a very powerful thing to allow a patient to have such an active role in their course of treatment. I would definitely like to see where the research goes, or maybe see how a patient's quality of life is affected by a course of treatment like this, or to see what their perceptions are on the doctor-patient relationship in this instance. I'm really just excited to see where the research goes and how the technology evolves going from here. So it's definitely something to look forward to. So to end today's video, I want to read a statement from the Pan American Health Organization about health equity. And I think that it just does a really good job of summarizing a lot of the stuff that I've talked about today. So it goes on to say, achieving health equity requires that women and men, girls and boys, have fair opportunities and access to conditions and services that will help them to achieve optimal health. Equity in health demands that we care about the range of human experiences and work towards making healthcare and policies responsive to all people by paying attention to their diverse identities as people and by paying attention to the diversity of their daily lives. Now, in summary, they really say that equity is the means and equality is the outcome, which I think that's a great way to look at it. So I hope that helps you to understand these concepts a little bit better, and I really look forward to making another video, so I'll see you guys next week.